Welcome to Part 2 on urinary health in continuing care settings. It is based on the best practices that are described in the provincial infection control document called Guidelines for the Prevention and Treatment of Urinary Tract Infections or UTIs in Continuing Care Settings. This presentation will focus on strategies that will help reduce the frequency of catheter-associated urinary tract infections, also known as CA-UTIs. As mentioned in Part 1 of our presentation on urinary health, urinary tract infections are the most common bacterial infection found in older adults. In the community, UTIs are the cause of 25% of bacterial infections in older adults, and in long-term care, that number rises to 30% of bacterial infections. We know that diagnosing a urinary tract infection in long-term care is difficult, and staff often rely on triggers like changes in behavior and a positive urine dipstick, rather than looking for real signs and symptoms of an infection. This practice often leads to misdiagnosis and unnecessary treatment with antibiotics. Inappropriate use of antibiotics in both long-term care and the community can cause an increase in resistant organisms like MRSA or ESBL, as well as harmful interactions with other prescribed medications, or may cause drug-related side effects. What is a catheter-associated urinary tract infection or CA-UTI? It is an infection of the urinary system, which could be in the bladder, ureters, or kidneys, in a resident who has an indwelling urinary catheter. From our surveillance of all urinary tract infections, we know that 75 to 80% of urinary tract infections are found in residents who have a catheter. The bacteria causing the infection can come from the resident's own bacteria, which is also known as normal flora. Bacteria can contaminate the catheter if sterile technique is not used at the time of insertion. Transmission of bacteria and infection can also occur if good technique is not used when providing daily catheter care and maintenance. Catheter-associated UTIs often result in much more complicated infections that can increase costs for the resident as well as the healthcare system, because the resident may need to be transferred to hospital and require either IV into antibiotics or be on antibiotics for a much longer time. This often means it takes longer for the resident to improve, and sometimes they don't get better or develop other complications such as sepsis and may even die. In this presentation, we will review what care practices or strategies we can follow that will reduce the risk of a catheter-associated UTI from occurring. Things like not putting in catheters if they're not needed and getting them out once they are no longer necessary, using only aseptic technique to insert catheters, and making sure staff are educated about aseptic technique and using appropriately. Making sure that catheter and drainage systems remain closed if at all possible, and that the drainage bag and catheter are checked daily for any problems in function. Also, the need for policies and procedures to promote these practices. What role do catheters have in urinary tract infections? This is a picture of an indwelling urinary catheter being held in place in the bladder with a balloon that is inflated with sterile water. Catheters are invasive devices that interfere with the body's defense mechanisms. The catheter keeps the urinary meatus, or the opening to the bladder, opened all the time, which allows bacteria to migrate in. The urine we pee normally helps to clean the urethral area, and this can no longer happen with a catheter in place. The balloon that holds the catheter in place prevents the bladder from totally emptying, so the urine that remains in the bladder becomes a great place for bacteria to grow. Also, the catheter is always going to cause trauma and irritation to the urethra and the neck of the bladder through the motion and pulling on the catheter. And of course, we all know the worst injuries happen when the catheter gets accidentally pulled out. What also happens is that biofilms start to develop on both the inside and outside of the catheter, which protect the bacteria. This is a picture of a biofilm under an electron microscope. Biofilms are complex communities of different microorganisms, proteins and salts that attach to the catheter surface and produce a protective slime coating that is able to resist the body's defense mechanisms as well as antibiotics. The only way to get rid of a biofilm is to remove the catheter. The longer you have a catheter in place, the more colonized your bladder will be with bacteria, which increases your risk of developing a urinary tract infection. What is a bundle approach to resident care? It is a collection of practices that is used to reduce the risk of harm or infection for residents who are at more risk because of treatment or a medical device like a catheter. If only one intervention or activity is done, harm reduction may not happen, but when a group of interventions are done together or combined, they can significantly improve resident outcomes or health. A catheter-associated UTI prevention bundle includes the following elements: hand hygiene, avoiding the use of catheters when they are not required, using only aseptic technique when inserting catheters, following the recommended daily care practices for the maintenance of indwelling urinary catheters, and having policies and procedures in place to support all of these practices. We know that hand hygiene is important in all that we do, and we should always look for ways to improve that practice. Let's talk about appropriate catheter use, which means we only insert catheters for appropriate reasons and that catheters stay in only for as long as they are needed. Studies and chart reviews in acute care have found that in 21% of the time, there was no documented reason for the insertion of a catheter. It was just put in. It has also been shown that in cases where the catheter may have been necessary at the time of insertion, half of the time, or 41 to 58% of the time, once the reason was resolved, the catheter was not removed in a timely manner. In many acute care situations, doctors are not even aware their patient has a catheter unless one of the nursing staff asks to have it removed. We also know that having a catheter does not feel comfortable for the resident and affects their ability to transfer and mobilize, which can often lead to other complications like pressure ulcers, deep vein thrombosis, and possibly pneumonia. Catheters should not be inserted or continue to be used in situations such as using a catheter for residents who are incontinent rather than providing them with good and timely nursing care. We would not insert an indwelling catheter to collect a urine specimen, but we could use an in and out catheter. We would not use a catheter to make workload easier for staff. Alternatives to an indwelling urinary catheter are using intermittent catheterization for residents with a spinal cord injury or bladder emptying dysfunction, external condom catheters for male residents without urinary retention or bladder outlet obstruction, where it is available, using a bladder scan or a portable ultrasound machine to monitor for urinary retention or large volumes of residual urine is also another way to monitor. For those who do need an indwelling urinary catheter, the need for a catheter should be reviewed on a regular basis. Other forms of incontinence not related to bladder emptying dysfunction or retention can be managed as described in the other urinary health education module. We have reviewed what is an appropriate and inappropriate catheter use. Now we will look at the second part of our bundle of care, which is the proper insertion of urinary catheters for residents who do need them. Only trained healthcare workers who are skilled in aseptic technique and know how to properly insert a urinary catheter are the ones who should be providing this care. Inserting a sterile medical device like a catheter is a skill that needs to be taught and verified on a regular basis, especially if there is a change in products or policies. Ensure that staff are compliant with proper hand hygiene practices and that they have access to hand hygiene products at the point of care. Before inserting the catheter, make sure that the resident or support person is provided with information about what you are planning to do and that you have all of your sterile supplies and personal protective equipment that may be required. As mentioned before, infection can occur through the external surface of the catheter when it is inserted. So before setting up for the sterile field and equipment, it is best to ensure that the urethral meatus and the perineal area is free of any secretions or encrustations by cleansing first with soap and water. Ensure you have all the sterile equipment and supplies you need for the insertion: sterile gloves, drape, and sponges, sterile or antiseptic solution for the cleaning of the urethral meatus, which should be done at least 3 times. A single-use package of sterile lubricant jelly should be used to coat the catheter before insertion. Ensure you use the smallest catheter size possible that provides good drainage but will minimize urethral trauma. After the catheter is inserted, allow the urine to drain before the balloon is inflated. If a drainage bag is not already connected to the catheter, attach the sterile drainage bag to the catheter end and secure the tubing and bag so that it is below the level of the bladder to facilitate drainage, but not in contact with the floor. Properly secure the indwelling catheter by anchoring it to the upper thigh in women and to the upper thigh or lower abdomen in men in order to prevent movement of the catheter and urethral trauma and tears. Document information about the insertion on the residence chart. We won't cover it here, but in the guideline there is information about technique required for intermittent catheterization done in a continuing care setting. Now that we have covered proper insertion, we will look at the third part of our bundle, which is proper maintenance of indwelling urinary catheters. Perform hand hygiene immediately before and after contact with the resident or the resident's environment. Use gloves and other personal protective equipment if required when working with the catheter or the drainage device. It is very important to make sure that there is a free flow of urine from the catheter to the drainage bag at all times. We can do this by ensuring that the catheter is properly secured to the upper thigh, that the resident is not lying on the catheter or tubing, that there is no kinks in the catheter or the tubing, and that the drainage bag is always positioned below the bladder to make sure there is no backflow of urine into the bladder. We also want to make sure that the catheter bag is not on the floor where it will be contaminated. It is very important that the inside of the catheter and drainage system remain sterile and continuously closed if at all possible. Avoid disconnecting the catheter and the drainage tube. This will help prevent germs from getting into the catheter system. If the drainage tubing becomes accidentally disconnected, consider the possibility of changing the catheter and tubing. If you do need to open the catheter and tubing, make sure you do not touch the ends with your hands and gloves. Wipe the ends of the catheter and tubing with an antiseptic solution like an alcohol rub before disconnecting and, if required, before reconnecting them. For residents who prefer leg bags, rather than disconnecting the drainage from the catheter in the morning and night, there is an option to use a linkage system where the outlet tap of the leg bag is left open so that the urine collects in the larger bag without breaking the closed drainage system. You would need to make sure that this option with extra tubing at night would not create an unsafe environment for your client. Other things to remember are: empty the drainage bag on a regular basis depending on the size of the drainage bag. Before moving or transferring the resident, ensure that the drainage bag is emptied to make transferring easier. Use a separate clean container for each resident when emptying the urine drainage bag. This means there should be no sharing between residents, and in a semi-private room the container should be labeled to prevent a mix-up. When emptying the catheter bag, make sure there is no contact between the drain spigot and the non-sterile container, as again this is where bacteria can enter into the urine bag. Wash the catheter entry site daily with soap and water and after bowel contamination, but make sure to avoid using rigorous, frequent cleansing of the catheter entry site or the use of an antiseptic solution rather than mild soap and water. Practices to avoid. Bladder irrigation causes a break in the closed system and so should only be done with a physician's order and for a specific reason. It is no longer recommended to routinely change catheters or urinary drainage bags at fixed intervals like we did in the past. Change should be based on clinical indications like infection, obstructions, or when the closed system is compromised. Change the bag when the Foley catheter is changed and as needed because of accumulation of sediment, discoloration of the bag, odor, leakages, etc. If the collection bag and tubing needs to be replaced, ensure that you use good aseptic technique as I have previously described. Urine specimens for culture and sensitivity should only be sent if there are symptoms of a urinary tract infection, which you can find in the other training module and some of the other UTI toolkits. If the resident has been on antibiotics, there is no need to send a follow-up specimen because we know anyone who has a catheter will continue to have bacteria in their bladder 100% of the time. If a specimen is required, then follow the instructions for specimen collection as discussed in Module 1. We will now discuss policies and procedures that will help to support the recommended practices we have talked about. Policies and procedures should be developed for recommended catheter use and discontinuation, insertion, and management techniques. Staff should receive education and training relevant to these policies and procedures. Encourage and empower nursing staff not to proceed with catheter insertion if criteria are not met, and to discuss alternatives with physicians and families. Routine admission assessment and care planning should include documenting the presence and the need for an indwelling catheter based on a continence assessment, education, and discussions with residents and/or their supports. If the criteria are not met, the catheter should be removed. Only healthcare providers trained in aseptic technique and the proper use of sterile equipment should be allowed to insert urinary catheters. Competence in this skill should be verified and reviewed on a regular basis. A checklist for the routine maintenance of catheters should be developed. The checklist will allow for easy documentation of daily catheter care. Ensure that staff are educated in and compliant with proper hand hygiene practices, and that includes the use of gloves, and also have access to hand hygiene products at the point of care. We now know that urinary tract infections are one of the most common infections in continuing care settings and can often result in hospitalization, increased use of antibiotics, and complications for our residents. Almost 80% of the UTIs found in long-term care are in residents with indwelling urinary catheters because they provide a direct opening to the bladder either for the resident's own bacteria or bacteria that may come from their environment or through contact with healthcare workers. If we include bundles of care that are known to reduce the risk of catheter-associated urinary tract infections, this will greatly improve health outcomes for our residents. The CA-UTI prevention bundle includes good hand hygiene at the point of care, making sure that only those residents who need indwelling catheters have them, ensuring that when inserting a urinary catheter, it is done by someone who knows how to do it properly using aseptic technique, ensuring that the urinary catheter is monitored and maintained daily following the recommended practices, which are making sure the catheter is secured, maintained as a closed drainage system, and that there is no obstruction to the flow of urine. The collection bag is below the bladder, emptied properly, and is off the floor. And finally, that there are policies and procedures and education in place to support this standard of care for residents. Thank you for your time today. If you have any questions or concerns about the information in the presentation, please feel free to contact one of the 2 email addresses listed below. This information is based on guidelines for the prevention and treatment of urinary tract infections in continuing care settings and can be seen at the Ministry of Health website, which is indicated on the slide. Again, thank you for your time. In addition to the references that are listed in the UTI guideline, the next 3 slides will show additional references that were used in the making of these educational PowerPoints.